So as we start up, just a couple of acknowledgments. First, we appreciate the support of the county commissioners represented here again today by Commissioner John O'Grady. Thank you, Commissioner. And the support of the state and the governor represented by the First Lady, Karen Kasich. Karen, thanks for being here. And as I was reminded by the good Dr. James, and I think a couple of us maybe forgot this morning, Happy Valentine's Day to everyone. Lest we get too uber-focused here. So I know a lot of you had very interesting discussions. I was party to some of them, and we look forward to hearing what you've learned. But before we have that discussion, before we process what it was we talked about, we want you to hear from Dr. Sharon Davies. Professor Davies will share some important facts and considerations about one of the toughest issues we're tackling, and that's what we've been talking about all morning, and that's the disparity gap. She's also graciously agreed to facilitate a discussion for this group that'll help pull some of these pieces together here this morning. Sharon Davies is the Executive Director of the Kirwan Institute for the Study of Race and Ethnicity, another invaluable resource right here in our community. She's also the Gregory H. Williams Chair in Civil Rights and Civil Liberties at the Michael Lee Moritz College of Law at The Ohio State University. She's worked in private practice for several prestigious law firms. As well, she's served as an assistant U.S. attorney in the Southern District of New York. She joined the OSU Law faculty in 1995, and her primary research areas are criminal justice and race. We're pleased to have her with us this morning to help us better understand the opportunities to close the infant mortality disparity gap here in Columbus. Dr. Davies.
Thank you very much. It's a pleasure to be here with you all and to have an opportunity to interact with you a bit as you begin to think about the dimensions of the work. I hope that the feedback here won't be too bad, but if it is, I think we'll have to switch to a microphone, but hopefully it won't be because I may like to move a bit, but I guess it might be all right. We'll see as we go. So I know that you all were presented in your first meeting and in a little of the presentation by Dr. Gunn this morning with some pretty grim facts and figures, and it's not my intention to go through that material again. My dear friend, Dr. James, is the nation's one of the nation's leading stars on understanding those disparities, and so at bottom, what they mean for us that I want to focus our attention on today is the question of how it is so many years after successes of the civil rights era, when we thought that we had really accomplished so much when it comes to race in this country, that we still find ourselves presented with the reality that black infants are still more than twice in many communities likely to die before their first birthday than white babies. And this is nationally as well in Ohio, as we know. So this is not something that is confined to our community, but it is one that is deserving of your attention. When researchers have begun to think about that question, their premises were different depending on when they came to it. Historically, traditionally, we tended to look pretty closely at the level of the individual. And so really we were talking about mothers and what was going on with mothers, oftentimes looking biologically, oftentimes looking at behaviors of mothers. And it's only relatively recently that we've begun to see researchers expanding their models in important ways that will show that that are designed to uncover some of the things that are frequently referred to as social determinants that surround the lives of mothers that are now, we are starting to recognize are important to the question of what we might do about this. The reason why black and white infant mortality rate gaps are so important is because we know that they reflect something that's more than simply a picture of individual maternal health. They reflect a picture of a community's health. It's universally recognized that these are a barometer for the health of an entire community. And so we can think about what we know from these grim facts as a portrait, if you will, of community well-being and community non-well-being. And because that it is true, and we think broadly about community health when we talk about infant mortality rates, we should also take a wide lens view when we're thinking about the interventions that you all might come up with to address these disparities. And certainly to reach the very ambitious goals of this task force, it's going to be necessary, I think, for you to take a very wide-angle view of things. That will be quite different from the way in which we have traditionally approached this question before, and it will cause us to think about the poor health experiences that are a part of communities that go beyond poor birth experiences. Because if we really began to study the connections between the communities where we see high infant mortality rates, we would also discover that in those same communities, they are struggling with high rates of asthma and thyroid disorders and diabetes and hypertension and heart disease and cancer. And they have significantly lower life expectancies in those same communities as well. So really, the work that you are embarking on is work that can have multiple effects on our community. And some of them relate to health, but not all of them. We know that we recently just finished up important work by the Education Commission, and the Education Commission was focused on disparities, only disparities in academic achievement and academic attainment. If we think about disparities more broadly, we would see the connections between disparities in the education realm, disparities in the health realm, disparities in the justice realm, disparities in essentially every important realm of human life. And so I want to start there broadly, but because the disparities in infant and maternal health are not actually isolated. Now, when I say that, I'm always a little bit fearful because it may seem as though I'm asking you all to consider taking on the problems of the world, or at least all of the problems of our community. And, you know, in a sense, I'm kind of saying that if you really do what we need to be done to address infant mortality disparities, you will, in fact, be taking care of, or addressing at least, a number of other problems simultaneously. So I just want to plant that seed and also say that a lot of times when we embark on something like this, one of our major concerns is cost. Cost comes up. Limited financial resources are part of our conversations, and that's natural and understandable. But I think what we don't do very well is that we don't often think about the costs that we are already paying. And so this slide really focuses our attention a little bit on that when you think just about prematurity. And preterm births costing Ohio $1 billion a year. And one of the most startling statistics that I heard up on the screen was that 0.2% of 1% of the Medicaid population requires neonatal intensive care unit care, but that represents 15% of all Medicaid expenditures. And that's just one dollar figure that I could have brought to focus your attention on. The point really is that we don't think about all of the investments we're already making when we have conversations about how much is this going to cost us. Instead, we fail to realize that we are already investing, but what we are investing in, unfortunately, is failure rather than strategies of success. And so if we take the turn that researchers have been urging more recently that we take, we would not focus simply on prenatal care as the answer to this problem. But we would recognize that prenatal care is only a part because it does not consider the socioeconomic context in which mothers live. It medicalizes a problem, and it suggests incorrectly that we should be able to identify a medical silver bullet to this set of challenges, really, that you are thinking about. And so our recommendation from researchers that focus on social determinants of health is that we broaden our lens. Now, to explain that a little more deeply, this is a part of systems thinking. Essentially, systems theory suggests that we all live in a very complex system of interacting and reinforcing structures. And those structures surround us. We're at the center of it, and there are aspects of ourselves, our bodies, our families, our genetic predispositions that are important to what happens to us in life. But they are not the only important things. And certainly lifestyle factors are important as well. But more important, those who are believers in social determinants theory are telling us, are the networks that we have, sometimes called social capital networks that provide support to us, or when they're missing, don't provide support to us. Also, the conditions in which we live, in which we work, in which we play, in which we learn every day, the quality of the structures that we are taking part in our daily lives. So that might be the quality of our schools, the quality of our workplaces. Are their workplaces clean and healthy and safe, or are they exposing us to toxins and other stresses? The quality of our exposure to healthy food sources would be another. All of these, when we think about it, really make a lot of sense when we think about our own health. When we think about other people's health, we have a tendency to focus in on what they're doing wrong, or maybe they're not seeing doctors that they need to see, prenatal care in this context. Maybe they're not complying with the advice of the professional health folks that they come in contact with. But we don't spend enough time thinking about all the things that surround the lives of the ill. And finally, most broadly, we have to also factor in the socioeconomic forces, cultural forces, environmental conditions that are part of our everyday lives as well. And if we did that, the set of interventions that we would realize that we need to actually consider, put on the table, would be much bigger than making sure that everyone has health coverage that allows them to see that health professional, making sure that everyone has access to quality prenatal care, or maybe even, as Dr. Gunn was saying, postnatal care and interconception cares as well, that it actually will go beyond that. Now, to really embrace that, I want to say up front that this is going to require a willingness to move beyond some very powerful habits of thought when it comes to health. And one of them is the idea that is a very powerful idea that poor health in particular is the result of poor choices and poor behavior. Now, we don't think that very often, actually, when it comes to ourselves. And this is something that psychologists call fundamental attribution error. What fundamental attribution error is the very human tendency to think about the bad things or misfortunes in our own lives as being caused by external factors, whereas thinking about the bad things that happen to other people's lives as being caused by internal characteristics. Fundamental attribution error allows us to think that the reason why we have so many babies dying is because mothers are smoking when they shouldn't, or they have bad eating habits, they are obese, they're not exercising properly, they're not getting good enough and timely care. Now, that's a piece of it, and we certainly aren't suggesting for those of us who think that we have to think about this more systemically and thinking about the social determinants of health. We don't reject the basic and important conclusions that individual behaviors impact health outcomes, but we only suggest that those disparities that we see cannot be explained simply by individual behavior. Research really shows that mothers who do not smoke, black mothers who do not smoke, still have worse outcomes with birth than do white mothers who do smoke. And we also know that there are other perplexities that are involved that are connected to race, or that at least is where researchers are going next. For example, we also know that more educated, professional black mothers have higher negative birth outcomes than do lower educated white women. So a black mother with an advanced degree could have statistically different and more negative birth outcomes than white women with a high school diploma. And so all of those things have caused researchers to look more broadly, or to begin to look more broadly at the social determinants of health, and even the possible effect of race itself on outcomes that are concerning us. Now, you saw this morning, and I think last week as well, that great iceberg picture. And another way of thinking about social determinants of health is this one up on the screen. Now, I've already said use a wide lens rather than a telephoto lens, so forgive me for mixing my metaphors here. But sometimes this one is helpful in thinking about how it is that different social conditions really can result in unwanted disparities in health. So the thing to focus on with this particular slide is the roots. Sometimes, to mix my metaphors even more, we think about the things that are displayed here as root causes of health inequities as upstream costs or upstream factors. And that is just because we know things travel downstream. If the things that happen first are going to impact things that happen later, they're sometimes referred to as upstream factors. Here at the roots are the upstream factors, really, all the kinds of things that that can disproportionately result in negative health outcomes versus the kinds of things that we like to surround our own children with, and ourselves with, to secure better health outcomes. So what are the things that I'm talking about? High-performing schools, good performing health facilities, clean environments, both clean environments in our workplaces, but also where our homes are located, good sources of income streams, sound transportation possibilities, good food, healthy food, employment, quality housing, and so on. Not everyone has this, as we know. And those who don't have it, and where the negative conditions, the converse of all of those quality things, are concentrated, can lead to very different results that are graphically depicted here by a healthy tree and a less healthy tree, maybe a dying tree. And really, the thing to notice about this is that there's no suggestion that there's not illness in communities that are the beneficiaries of good social determinants, those positive roots that are on the right-hand side of the screen. But rather that the communities are in a stronger position to weather them. And so you can see how when inequities are high in a community and community assets are low, that results in health outcomes that are worse and unwanted. So this has led researchers to create a number of new models that are more expansive. You heard about one this morning, and that's the life course perspective. There's also the socio-ecological perspective, and finally the social determinants of health perspective or approach that really focuses on multiple aspects of individual and community health at once to help explain outcomes. The most important thing about social determinants of health is that I'll focus on today. One of the most important things is the significance of place in our lives. We don't always pay as much attention to the significance of place to our health, but we have begun to see articles like this that are reflecting an understanding that we need to focus on neighborhoods, zip codes, geographic areas when we think about interventions that could help us avoid the kinds of infant mortality disparities that you all are concerned with. So again, we're not saying that the other models are wrong, they're just incomplete. And so we would take a wide-angle view rather than a telephoto view. Now, place is variable, as we know. And if we think about infant mortality, we can see pretty easily when we focus on where the hot spots of infant mortality actually are located, that what we are seeing are pictures of communities that are under high stress in multiple ways on multiple metrics. And so the hotspots of infant mortality are a way of seeing vulnerable populations under great stress, and these are one of many unwanted results. Now, one of the things that the Kirwan Institute for the Study of Race and Ethnicity does is we utilize GIS, Geographic Information Systems technology, to create maps, to really allow us to, or help us to visualize this. Because sometimes the seeing statistics on pie charts and other graphics really doesn't impact us in the same way that maps do. When we recognize on maps our own neighborhoods, our own communities, streets that we travel on every day. So this is one of the simple maps that we have created to look in a snapshot, really a very small period of time, too small in a lot of ways for us to be comfortable with, and ultimately we would want to have a lot more data than this. But this gives us a snapshot and a color view of low birth weight. It's a bivariate map, 2 variables of low birth weight and prematurity. And so if we look at this, we can see that different colors represent different amounts of infant low birth weight and premature birth in colors and in the lines that are on this map. And I'm not sure how well you can actually see it here because it's a light screen. But if we focused in on this, you would be able to tell that some, especially in some core neighborhoods in the center of Franklin County and Columbus, are the hot spots for low birth weight and prematurity. And so seeing this is a demonstration of what the Kirwan Institute refers to sometimes as the neighborhood effect that we are actually seeing here. 50 years of research has shown that neighborhoods have important effects on individuals' chances for success on a number of metrics. And this is just one picture of that. If we looked at another map that the Kirwan Institute has created about infant mortality, not just the two factors that I mentioned a moment ago, but the geography of infant mortality in Franklin County more broadly, we would see that a number of neighborhoods in Franklin County have rates that are distressingly high. On some neighborhoods on the south side, for example, are in the range of 20 plus infant deaths per 1,000 live births. And we would expect, for example, those kinds of numbers from countries like North Africa or Central America. Other neighborhoods have the darkest here colors are what we would be looking at on this map that show somewhere between 15 and 20 or 14 and 15 infant mortality deaths in these neighborhoods per 1,000 live deaths. And those would be the rates that we would expect from a country like Mexico or parts of more developed parts of Latin America. There's one part, we've produced a number of these maps and we can provide those to the task force. One of the maps that we've produced would show a part of German village that has 0 infant mortality deaths in a certain period of time of study, but directly across a street, that number would jump to 22 infant deaths. So that's the kind of stark separation that we are talking about, that we can actually map to show that the social determinants that surround people's lives are incredibly important and deserving of greater attention. Now, the kinds of things that Kirwan maps, in addition to single issue health disparities like infant mortality, is an overall view of the health of neighborhoods. We sometimes refer to these as opportunity maps because I can't say this more loudly enough. What we are looking at in the view of the Kirwan Institute is a picture of opportunity. And the truth is that we have differential opportunities that are based on our neighborhoods. And so what we attempt to do is sometimes to create what we call opportunity maps that really can help us see the very big differences in a single community like ours. We create them for communities around the country, but in a community like ours, if we look at different measures that we can secure data for that relate to neighborhood health or housing health, like median home values, poverty rates, vacancy rates, foreclosure rates, We look at information indicators around transportation and employment that would give us, make us focus on mean time commutes perhaps, or job access or unemployment rates. Other indicators around health and safety, like the number of primary care providers in a neighborhood, or incarceration rates or crime rates. And education, finally, student attainment rates, performance indexes, student attendance rates, which obviously relies on accurate information. So it gives you a sense of how vulnerable these kinds of measures are if we don't have our data collection systems operating in a good way. But when we put all of that together, we can create what we referred to as an opportunity index for our neighborhoods here in Columbus. And on this map, the parts of the map that are very pale colored would represent the lowest opportunity index that we are seeing, and the darkest colors represent areas that are very fortunate to have very high opportunity structures measured on all of a confluence of all of those indicators that I mentioned a few minutes ago. And so these kinds of neighborhood opportunity index maps have been very helpful to communities like ours in deciding where the resources need to be targeted in order to make our expenditures most cost efficient. And so counsels us to focus resources and energies on the communities that have the lowest opportunity index scores. Now, if we combined this kind of map with the map that I showed you a few minutes ago, the infant mortality map of the community, and the neighborhood opportunity index map that Kerwin has created, we will be able to see the parallels actually between some of these areas. And so, for example, we would be able to see high infant mortality rates in a low opportunity community of Linden. We would see high infant mortality rates in some of the communities on the Near East Side that have a low opportunity index. We would see the same thing for Hilltop and Franklinton neighborhoods, and we would see the same thing for the Near South Side. So these maps are really telling us essentially the same thing, or reaching the same conclusion, that we have to focus on improving the conditions that surround the lives of mothers who live in these areas of, I'll just go back, of high infant mortality, in order to expect to reduce the disparity gap that you all have said you want to reduce by 50%, the black and white infant mortality gap. To do that, you would have to reduce black infant mortality in these neighborhoods by 60%. And so that is a very ambitious goal that will require a wide lens that focuses on all of the social conditions that surround the lives. Now, other cities are beginning to approach this in that way. And I know that towards the end of your study together, you will be focusing on Baltimore, you'll be focusing on Boston, I think, and there's some important things that are being done in those programs. One of the things that is most right about them, I think, is that they are attempting to take a comprehensive look and to break beyond those purely biological or biomedical and also behavioral models of yesterday. But they are also already getting some nice results, at least with drops in infant mortality. I want to encourage you to focus not just on drops in the infant mortality rate, though, but to remember to focus on the disparity between white and black infants, because these programs are having some success, but less success on that. And I think some of the reasons for that is that we have to have will. We have to have a real sense of clarity to tackle the kinds of social determinants that I have been talking about. Now, so far, the Baltimore Be More for Healthy Babies campaign, it's still a relatively young program or set of programs. I want to say that because I heard this morning a phrase, I think it was quick fix. And I just want to emphasize, this set of problems that you are trying to tackle were not problems that were developed quickly. The reasons why the neighborhoods of low opportunity look the way that they do is because we had a history of concentrating racial populations in areas of low population. Now, we did that by law for centuries of time, decades of time. And even when we eliminated law that did that, the Jim Crow system and other social customs that created those kinds of neighborhood patterns, we didn't do what we needed to do at that time to address the outcomes of the high segregation of black communities. And so what you all are really focusing on here are the costs of poor decision making, the decisions not to make investments at the time that we were making important changes in our law that equalized law but did not equalize resources that were available to the nation's citizenry. And so that means that the set of problems that you are tackling are long-term problems that will require sustained interventions. That's hard, I know, to ask, because we want quick fixes, and naturally so, because we have babies that are being born, and we have children who are living in neighborhoods like the ones that I put graphically up on our screens. The desire for quick fixes is natural, and it is right. We need to do what we can do, but we must understand that these are not going to be problems that will be resolved in 5 years' time even, or longer. And it also necessitates the need to measure these things carefully, gathering data and measuring outcomes for a long period of time. One of the best, I think, of the nation's programs or set of programs to do that, to take that long-term view, has been the Northern Manhattan Perinatal Partnership in the Harlem Better Baby Zone. Now, we had the advantage last year in Columbus to have Jeff Canada, the head of the Harlem Children's Zone, come to us and talk to us. He focused mostly on education disparities, but we're talking about the same thing. Whether we're talking about racialized health disparity, racialized educational disparity, racialized disparities in any realm of important social human life. We are talking about the same things and the conditions that need to be changed over the long term. Now, a lot of people have said to Jeff Canada when he talks, and he talks so beautifully, as we know, about that this is maybe something that the Harlem Children's Zone has been able to do because of the vast financial resources that have been successfully put together in order to fund that zone. And I remember what Jeff Canada said in response to a question like that when he was here in Columbus last year. And he said that we do not fully appreciate how much money we are investing right now in failure. And if we can stop investing in failure, the amounts, the payoff there will offset the costs of investing in success. So one of the first things that I think can be done and needs to be done here in Columbus, the Kirwan Institute is interested in doing it, but will require us having access to data across the city, is to first of all map all of our health-related assets that we have. We actually have a tapestry of health-related assets, but they are sometimes the products of Columbus Public Health, sometimes the products of Ohio Public Health, sometimes the products of the faith community, sometimes the products of our several excellent hospital systems. They are not operating in
Code Red A building, 5th floor, room A35, water flow monitor. Code Red A building, 5th floor, room A35, water flow monitor. Code Red A building, 5th floor, room A535, water flow monitor.
They do not operate in cohesive or coordinated ways, and they will have to do that. And the first thing that we have to do is to identify them, see where the gaps are, and to see where our leverage points are. There's a lot on this slide, and I'm running out of time, but this gives you a sense of some of the short-term and the long-term things that need to be done here. But I would say that you will see, even on the short-term list, that this takes a comprehensive social determinants view that includes quality care, prenatal, postnatal, between pregnancies, but also begins to explore or remedy problems in the built environment through blight removal, and the coordination of all the programs that exist here in Columbus that are focused on these things, but are not being coordinated in the way in which they need to in order for them to have optimal success. You have many of the right people on your task force. You have Anthony Trotman with Family and Job Services. You have Janet Jackson. You have members of the faith community. You have the right building blocks that would be able to approach the social determinants in a coordinated way, and I want to commend you for that. And we can take advantage of programs that exist here that are doing the right things, that have the right idea, like Dr. Pat Gabby's Moms to Be program that needs sustained funding over the long term. We cannot expect to see major changes that we can rely on in 1, 2, or 3 years. We can see from those graphs that were shown by Dr. Gunn this morning that 1 year it might be 1 point, the next year may be lower, the next year slightly higher. The thing that we have to keep our eyes on is the slope. The right direction over time, and you cannot make good decisions based on year-to-year results. This is going to take some time, and it's going to demand sustained commitment on our parts, financially and through our efforts. So I commend your work. I wish you well. I want to tell you that the resources of the Kirwan Institute are at your disposal. We want to help you. Thank you so much.
So one of the things we want to do as part of our wrap-up, in the interest of time, I'm going to take some liberties to expedite this. First, let me thank Dr. Davies for her wonderful presentation. I think she put a nice I'm not going to say cap on it, but that's the only word I could think of, or the conversations we have had at the individual stations as you walked around and you discussed. And I know there are individuals in each group who've taken notes. What we'd like to do is take a moment and hear from you, some of the highlights of your observations. This whole notion of social determinants, this whole notion of place and neighborhood being fundamental to any strategy that we have. This explicit consideration of race that has to be a part of any strategy or solutions that we come up with. And the data that drives this. I really love the mapping and the overlapping of the maps that Dr. Davies does, because when we talk about place and getting focused on place, that will be critical in the work. So can we take just a few minutes and have one or two ideas or issues that resonated with you in each of your groups through the gallery walk? Anyone want to start? I know it's a bit overwhelming, lots of data, and lots of opportunities. Yes, Mark.
I think I'll look to other people to correct me, but I think our group was struck by the fact that these are the same children and families in each of the 5 areas.
Good observation.
Was that brief?
Oh, I like it. Sweet, to the point. That was good. Thank you. They'll take them a while. Go ahead.
I would add that was, of course, you took our observation as well, that all of the issues were connected both at a micro level and either a place-based level, but also at a very high level, that there's a lot of connectedness, and sometimes there are policies that probably have been set up that actually are making some of this happen. So there was a lot of talk about other task forces that are being talked about, but thinking about the connections seemed to be something we kept coming back around.
Mm-hmm. Good observation. Anyone else? Some of these can be simple ahas. It doesn't have to be rocket science.
Do I have to do anything? No, I guess I'm on, huh? Dr. Long, same thing. I mean, the ecosystem is clearly stressed. Franklinton, I think, jumped out at us. As a matter of fact, I was squinting. I don't know if you could see the birth rate there, but we would be interested in knowing what the infant mortality rate is there, because the negatives are pretty high for Franklinton. Mm-hmm. And really an area that's going to be focused on in terms of redevelopment, and we hope those issues don't get pushed out somewhere, because they'll end up somewhere else, as we develop.
Good call out. Anyone else?
Bridge out of poverty takes more than just one system. The bridge out of poverty takes more than just one system. It's going to take several systems in order for, some of these distressed neighborhoods to actually get out of poverty so that we can have better birth outcomes.
Yes.
I guess thinking about when we first, just prior to the poster walk, the discussions about maternal health and looking at the gender impacts in all of these different areas, and how the challenges are based particularly for women specifically, and so it leads to the conversation of the health of women from the maternal care standpoint prior to pregnancy. Mm-hmm. And it highlighted in all of the areas that is overwhelmingly the case when it comes to the health of the women in our community.
That's a key aha for me. It's one of those things that you sort of know, but there's an affirmation to this, and that there's a role that everyone plays in the health of a community and the health of women in our community, which is paramount to this issue. Any other observations?
I would say also the living wage that is stated on the board over here states that a family of 3 has to make $51,000 in order to have, a better sustainable lifestyle. And that's, very, very aggressive based on where we are right now with, some of the wages that we're paying and minimum wage. And so we're talking about increasing minimum wage to $10, but that still doesn't get to the numbers that are defined on this chart.
Yeah, that's an overwhelming aha. Anyone else? Yvonne?
Do I have to touch this?
They'll turn it on.
It's not a departing trend, but as we're talking about the racial disparity and the gaps, Columbus African American population is 22%, yet overrepresented in a lot of the areas of stress and poverty indicated in many of these the statistics.
Okay. So again, a lot of information to absorb. For us, place is critical. We saw that in the results, the conversation from Dr. Gunn as well as Dr. Davies. So there was great intent in emphasizing that and great evidence around that. Explicit. Whatever we do has to be explicit in our consideration of race. The facts are here to support that. And the gallery walk, driving home the issue of systems, the systems in our community that exist and those that don't exist, and the systems that need to be improved. And bringing these three issues, our opportunities together to come up with solutions will be critical. So I think we're going to continue to challenge ourselves to think about ways in which our recommendations can make some inroads into these three places. So I'm encouraging us to continue to stay focused and ingrained in this information. Go back to the website if necessary. I think some of the slides we may even be able to see better, especially when we talk about targeting place, and that's going to be critical. Knowing and respecting the organizations that are doing great work, but I think the point that Dr. Davies raised about Jeffrey Canada's comment is, are we over-invested in failure? That's painful, because some of us may be in love with our baby, but it's failing. And that analogy of our baby is the programs that we have. And maybe the lack of systemness around programs and putting programs together to create systems and target those systems in neighborhoods that we can grow over time and have models of systems that need to be in place, so that when we start with 2 or 3 neighborhoods, we're creating models that can go from one neighborhood to the next, so that it's not once and done. Work's not going to be easy. I hope you walk away from this today encouraged and not discouraged, because it is bigger than an elephant, and as Mike said, we have to just do it one bite at a time, and I think our bites are going to be at the neighborhoods. Any other comments before I do an official wrap-up? Because we're dedicated to staying on time as best we can. Yes, Dr. James.
So I think one of the great things about the composition of the task force, about this, the walk that we did today, is I hope helping people to connect the dots between what I refer to as the cousins of infant mortality and infant mortality, and that if we address these things, we also improve birth outcome. The other piece that I think is really important, and I think it goes without saying, but I need to say it again, is that all of these things are nested in community, which means that we control them. They didn't get bad without our help, but they're going to get better with our help because we control them. Sometimes I do a little exercise that's math, but real simple. 2, 4, 6, 8. If I ask you for the next number, it's 10, and everybody knows that. We can predict that based on the behavior of the previous numbers to each other. It's the same thing with the risk for birth outcomes. In a neighborhood with poor housing, high crimes, unemployment, didn't graduate, what are we going to expect? And if we want to change things, then we have to positively affect that upstream stuff so that we can consistently get the kind of outcomes that we want.
No, I appreciate that. So I want to make sure we end on a high note. it is Valentine's Day. A lot of love in this room, a lot of love we're going to take out of this room for this work. This is truly the essence of that phrase, labor of love. And so I think it's fortuitous that it is Valentine's Day as we take the next step in this labor of love. Our next meeting is March 12th. We'll be back at Columbus Public Health. Bring your energy, bring an open mind, and be thoughtful about the recommendations and these areas of emphasis so that we can be impatient with action and patient with results over time. So there's probably a good balance in there. Thank you all and have a great weekend.